I will start by talking about cardiogenic shock updates, mainly focused on timing of cath as well as the use of LV support device, particularly in light of the new danger shock trial. I suggest you review my shock talks from before, the cardiogenic shock, as well as the Impella and the balloon pump talks. I want to start by showing you this classification. Whenever we talk about cardiogenic shock, people think about the SCAI stages A through E. However, another important classification is the types of shock. There are two big types of shock and four subtypes of shock that will dictate your management. And I want you to understand those. The first big type of shock is the acute MI shock, and this has two subtypes, STEMI and non-STEMI. And those are two very distinct subtypes in terms of study and management. Then you have the second big type, which is decompensated chronic heart failure shock, which has two subtypes, chronic heart failure cardiomyopathy with severe chronic CAD, not MI CAD, but chronic CAD, usually 3-vessel and or left main, and the cardiomyopathy heart failure shock without severe CAD, whether it's non-ischemic cardiomyopathy or it has revascularized CAD. Now, some comment on this classification. This MI non-STEMI shock and the heart failure shock with severe stable CAD have a lot of overlap. They are often difficult to distinguish simply because the heart failure shock with severe CAD frequently has type 2 MI and severe troponin rise. So both of those tend to have severe and overlapping troponin rise. So they are difficult to distinguish. The one key feature that I will use to distinguish those two is profound ST depression, mainly ongoing profound ST depression. That's the one that will gear me to say this is non-STEMI shock versus heart failure shock with underlying severe stable CAD. Now, another important idea is in terms of management. I mentioned the first caveat is those two tend to be overlapping. And the second big caveat is the only condition or subtype where we know immediate catheterization and revascularization works is STEMI shock. This is based on the shock trial published in 1999 and subsequently the culprit shock trial that only culprit PCI is what improves outcome, not doing multi-vessel PCI. So this is a group that benefits from immediate cath. Those two, there is no evidence that they benefit from immediate cath. And if you take an indirect message from the culprit shock trial, you can extrapolate it here. You should avoid treating what is not strictly necessary in a tenuous patient and rather wait until stabilization with diuretics, pressors, and support devices if needed. So the spirit of the culprit shock trial tells me that those preferably should not undergo cath immediately. Rather, you should wait until stabilization to go for cath. The only exception may be the non-STEMI shock with ongoing and profound ST depression. Again, the two key words that I will keep using with non-STEMI and shock is ongoing and profound ST depression, not based on a troponin. So shock from cardiomyopathy with severe left main 3-vessel disease, but no ongoing type 1 MI, meaning no ST elevation, or no profound and persistent ST depression does not require immediate PCI. Rather, diuresis optimized before PCI to reduce the PCI risk, reduce LVDP, raise blood pressure, and allow the patient to tolerate PCI without decompensating during your procedure. And again, when you have non-STEMI with heart failure, try not to do your cath emergently. The only time you need to do your cath immediately when you have that combination of non-STEMI with heart failure is if you have cardiogenic shock or massive intubated heart failure along with ongoing and profound ST depression. So those three, cardiogenic shock or massive intubated heart failure and ongoing and profound ST depression, that's the only non-STEMI with heart failure that I would take urgently for cath. And you need to meet, in my opinion, all three criteria. One, because there is no evidence of benefit, and two, because there is potential of harm indirectly proven via the culprit shock trial, where we know we should avoid treating what is not strictly necessary in a tenuous patient and rather wait until stabilization. Now, how can you get destabilized with urgent cath, especially urgent PCI? PCI manipulations can destabilize the patient via the following: the PCI contrast volume and supine position, but also very importantly, ischemia from guide engagement, especially if you have ventricularization of the guide, ischemia from transient flow occlusions, especially if you have difficult stent advancement and calcium, distal macro or micro emboli that would destabilize a patient who has at baseline preserved myocardial perfusion and TIMI flow. You have no reflow phenomena, side branch losses in a tenuous patients. All those may destabilize the patient. This is why emergent PCI in shock may get the patient worse before he can eventually reap the benefit from the improved flow. He may worsen his flow before eventually improving it. I hope this slide regarding the time of cath is clear. Only STEMI deserves immediate cath. The other ones wait until stabilization, except maybe the one with ongoing and profound ST depression. Now I want to discuss support device in cardiogenic shock, specifically in those four subtypes. When to use support device? Two major trials in the past, IABP shock 2 trial with balloon pump and ECLS shock with ECMO, and another one, ECMO CS trial with ECMO, have failed to show a benefit of balloon pump and ECMO in MI cardiogenic shock. Non-STEMI or STEMI cardiogenic shock. ECMO CS trial also included heart failure shock patients. Conversely, the recent danger shock trial, which used Impella CP, showed benefit of Impella CP in STEMI shock. Now, what's the difference between danger and those two other trials? One, it's a different device, but there is another difference that can explain why danger shock showed benefit with mechanical circulatory support, MCS, whereas the other two failed. The other two had two major pitfalls compared to danger shock in their inclusion criteria. They included non-STEMI, and that's a major caveat. A third of patients in those two trials were non-STEMI. They included out-of-hospital cardiac arrest. 78% of ECL shock patients and 45% of IABP shock patients were post-cardiac arrest. And in ECLS shock, the median time to return of spontaneous circulation was 20 minutes. And we know that out of hospital cardiac arrest, their mortality is dictated more by the neurologic insult. Most of their death is a neurological death, not a cardiac death. So including those will definitely reduce any potential benefit of any cardiac intervention. And along with those two major pitfalls, the median ejection fraction was 35% in IABP shock, and it ranged between 25 to 45%. And the EF median was 30% in ECLS shock, and it ranged between 20 to 40%, which tells you, particularly at the upper range of that EF, that shock was not purely cardiogenic in many of those patients. It might have been a post-cardiac arrest systemic inflammatory syndrome. Again, another reason why the support device may not work. And let me dig deeper into the danger shock Impella CP trial. So one, it did not have those two caveats. It selected purely STEMIs, which are the ones more likely to benefit from cardiac intervention versus non-STEMI. Hence, that classification is important. operators tend to lump those two together. They are distinctly different, partly because non-STEMI is very much overlap with chronic heart failure shock with underlying CAD, which is unlikely to benefit from emergent catheterization and maybe less likely to benefit from support devices. So the danger shock took very select STEMI patient with cardiogenic shock, less than 24 hours, the timing is important, and lactate over 2.5 millimole per liter undergoing primary PCI. Those patients were randomized to Impella CP versus standard therapy with PCI and inopressors. They excluded overt severe RV failure. They excluded out-of-hospital cardiac arrest unless the patient was responsive, Glasgow scale over 8. Typically, it means that the patient is able to obey to verbal command. And probably some of the patients that arrested in the ED or during AMS transport, those were not excluded. And key feature of that trial, the lactic acid was 4.6, which is in the moderate zone, 3.4 to 7, not too high, not too low. Median EF was 25%, unlike those trials. So it was purely a cardiogenic shock trial, not vasoplegic inflammatory syndrome trial. It was anterior MI in 71%. Duration of STEMI 4 hours. So this wasn't the STEMI late presentation. This was really acute early presentation with early shock, early management of shock. Median age was 67. Resuscitated cardiac arrest was 20%. But like I said, many of those were in the ED or in the cath lab, probably responsive to verbal comments. Based on my estimate, likely 30+% were on 2 inopressors, shock mostly stage C, 56%, and D, multivessel disease in 71% of patients, median systolic pressure 84, and men 79%. And Impella was placed before PCI in 47% of patients overall, so almost half before, half after PCI. They intended to place Impella before PCI in patients who were randomized before PCI. And in fact, in patients who were randomized before PCI and had their shock before PCI, they placed Impella before PCI in 85% of them. But close to half of the patients were randomized after PCI or their shock occurred after PCI. So that's why overall, Impella was placed almost half before PCI, almost half after PCI. And the protocol mandated that Impella gets used at maximum speed for at least 48 hours if no complications. And the median use at maximum speed was 60 hours. After that period, they recommended trying to wean the patient, then potentially explant Impella if he succeeds in the weaning criteria. Very little crossover. The standard therapy, only 1.7% of them received Impella, which I believe are 3 patients. About 3% of patients were upscaled to Impella 5 in both arms, and VA ECMO was used in 12% of the Impella arm as upscaling and 18% of the conservative arm. And in this trial, using those very select STEMI and cardiogenic shock criteria, Impella CP reduced 6-month mortality by a dramatic absolute value of 13%, which is massive. And here I want to remind you that in the original shock trial, which showed a mortality reduction with revascularization in STEMI shock, the mortality reduction was about 13% at 6 months. So this is as good as you can get. And now we have 2 proven interventions in STEMI shock. 1 revascularization and 2 Impella CP. Danger, very selectively recruited. STEMI shock that is recent. It was recent STEMI, median 4 hours, and recent shock, less than 24 hours. And severe, yet not too severe and not post-prolonged out-of-hospital cardiac arrest. And this is the U-shaped concept that I discussed before. In cardiogenic shock, you need to find that soft spot of patients who would benefit from your support devices. If you take the early stage C that is responsive to low or medium inopressor doses, those are less likely to benefit from mechanical circulatory support. If you take the deteriorating stage D on whom you need to keep upscaling your inotrope and whose lactic acid keep rising above 5, then above 10, and it has been ongoing for more than 24 hours, this one is also unlikely to benefit from mechanical circulatory support, because by that time, they probably have irreversible multi-organ injury. This is a sweet spot that is likely to benefit the most from mechanical circulatory support, within hours of stage D or rapidly progressive stage E, within hours. And this is the idea, and I think that's part of the reason danger shock succeeded. Partly the device, but partly the selection of STEMI shock that is recent and early intervention within hours of stage D or late stage C. It took 10 years to recruit 355 patients in danger trial, which some may criticize, but I think this is a virtue of this trial. They narrowly selected the patients who are most likely to benefit. It's a pure and excellent trial. And in that study, there was more significant benefit if multivessel CAD, as in here, if your initial mean blood pressure was less than 63, and in men. There was no benefit in women, but this subgroup was small. While Impella CP reduced death dramatically, it was associated with more complications. There was almost double major bleeding risk of 22% versus 12%, limb ischemia 5.5 versus 1%, much more dialysis 42 versus 27%, and more sepsis in Impella versus standard therapy. Now, some of those are what you call survival bias, meaning you had much better survival with Impellas, therefore much more likely to see those complications, especially dialysis in those patients. And you can see here the list of complications, which were all increased with the Impella CP. And there was 12% rate of hemolysis with Impella CP, which may have contributed maybe to higher risk of renal failure, but I think this is more survival bias, the need for more hemodialysis. Also, because those patients survive more with more complications, more patients in the Impella arm were still in the hospital at day 30. 23% were still in the hospital at day 30. So even though Impella saves lives, this comes at the cost of more complication and prolonged investment in hospital stay and resources to keep those patients alive. And this is the survival curve of standard therapy versus Impella. And notice the late spread in survival, which shows you how much the early Impella use and early LV unloading protects the LV pump function over the long term, but it also protects the kidney function and organ function over the long term once you survive those early complications. The late death between 30-day and 180 days in the standard arm were pump failure death, but also multi-organ failure death. And both those late pump failure and multi-organ failure were protected by the early use of Impella, which protected the heart early on and allowed it to recover and protected end organ perfusion. The early Impella complications explain that the benefit was not clear early on. Those who survive those early complications sustain their survival long term and reap the early benefit of Impella unloading on LV recovery and on long-term heart function, but also on long-term end organ function. So here I will complete my initial slide. And this is an important slide for you that I think you should print at that, and that summarizes my cardiogenic shock update. So the acute MI shock STEMI is the one that benefits from immediate cath and is the one proven now to benefit from Impella CP based on the danger shock trial, and Impella CP for MI and shock less than 24 hours. Conversely, the non-STEMI and the heart failure shock, there is no data for immediate cath and no definite benefit of any particular support device. I would not extrapolate the danger trial result to non-STEMI and heart failure shock with severe CAD. That said, I would still follow my algorithm of rapid escalation strategy and consider escalating to MCS, mechanical circulatory support, within 24 hours or within a few hours in those patients if they are deteriorating on pressors. Not specifically Impella CP, keeping in mind the lack of established benefit of any support device, and beware of the MCS high complication rate, and beware of the U-curve and of the unfavorable feature that could argue against MCS in those patients. And in all those 4 subtypes, avoid support in the comatose post-out-of-hospital cardiac arrest most often. So cardiogenic shock in general, to summarize it, emergent cath only if true MI-induced shock, which is ST elevation or plus or minus non-STEMI with ongoing and profound ST depression, as per the original shock trial. Impella CP mainly for STEMI shock, less than 24 hours, plus not for post-out-of-hospital cardiac arrest, except responsive post-out-of-hospital cardiac arrest. And here I want to give you a reminder of the shock stages and of the rapid escalation strategy that I apply to all patients, even those patients with non-STEMI shock or heart failure shock. The stage B is not shock, is pre-shock. Those patients have impaired hemodynamic on the Swan catheter, low index, high filling pressures. They may be hypotensive, low or borderline blood pressure, but the key idea is that they have normal lactate, normal perfusion. Stage C, which is the classic shock, you have hypoperfusion and lactate is between 2 and 5. So over 2 and between 2 and 5. Over 5 will make it stage D. So lactate is between 2 and 5. You typically and overwhelmingly are hypotensive, less than 90, although there is a small subgroup that is normotensive. This is what we call the normotensive shock. So they have normal blood pressure, usually low normal, 90 to 100, 110, no more than 110, but along with elevated lactate. So the key feature here is elevated lactate. But what makes it C as opposed to D is that you stabilize with one vasoactive drug classically or one mechanical circulatory support, but typically here we only need a drug, not mechanical circulatory support. So you stabilize and your lactate start declining and goes back to less than 2 with one drug. On the other hand, stage D, you need any of those. Your lactate is either over 5 and between 5 and 10, or your ALT more than 500. In stage C, ALT may be between 200 and 500. That is another sign of hypoperfusion beside lactate. So stage D, lactate is 5 to 10 or ALT more than 500. But more importantly, it's the trajectory. Stage D, he's getting worse on one vasoactive drug, small to medium dose, and you're requiring to go high dose of one drug or multiple vasoactive drug or one drug and one device, or you're escalating a device. So the key word here is upscaling. You're not responding to just one medium dose of a drug. It's upscaling. It's a bad trajectory. Or your lactic acid is high to start with. Frequently, those patients are anuric. Stage E is the extremist, is the one that is deteriorating despite multiple vasoactive drugs or despite multiple vasoactive drugs and 1 or 2 mechanical devices. So they are on 3 drugs or 3 combos, 2 drugs and 1 device, and still deteriorating. Their lactate tends to be more than 10, pH less than 7.2. Up front, their systolic pressure may be less than 60, and that helps you define stage E. If you haven't started yet your drugs or upscaled your drugs, but at baseline their lactate is over 10, or the systolic pressure less than 60, or pH less than 7.2, those are likely stage E, even if you haven't seen the trajectory yet. Keep in mind, when I talk about lactate, I'm talking about lactate in shock, not post-cardiac arrest. Immediately after cardiac arrest, your lactate may be very high, and it's reflective of how bad your cardiac arrest was, how prolonged, how long it took you to have spontaneous circulation, how long it took to start CPR. So the lactate after cardiac arrest reflects how bad the cardiac arrest was, the prognosis of cardiac arrest. It doesn't reflect the shock itself. So this is lactate level prognostication of shock itself, not post-cardiac arrest per se. And focus on your trajectory in your decision-making, not just the static number. Do I need to upscale or downscale my vasoactive drugs? And is lactate going up or down? You use those values, 2 to 5, 5 to 10, over 10, to make your initial classification, but focus on how it's trending to eventually correct your classification. And this is my algorithm for cardiogenic shock. These are the 4 stages, or the 3 stages if you start by cardiogenic shock. So initially, for stage C or stage B, pre-shock that is not responding to diuretics, you give small to medium dose of inopressor, and you place a swan. You don't need mechanical circulatory support for those, as I showed in my U-shaped curve. Inotrope responsive stage C, you don't need mechanical circulatory support here. Now, if you're trending in the wrong direction, stage D, then you need short-term mechanical circulatory support, and more readily established to be Impella CP in STEMI-shock. And if they keep deteriorating, then you upscale your mechanical circulatory support to Impella 5, ECMO, as they did in danger shock, and you up-titrate your pressors. And when I talk about escalate quickly. They are trending in a wrong direction using inopressors. Think of mechanical circulatory support. They keep trending in the wrong direction. Think of upgrading your mechanical circulatory support. Make sure you upscale within few hours. Don't delay your management. Don't wait more than 24 hours in a deteriorating patient. By then, you will be here, and there is a questionable benefit of anything you do at that point. Now, I want to remind you, as I explained in the past, balloon pump still has a value, particularly in heart failure shock. There is a hypothetical benefit of balloon pump in heart failure shock more than in STEMI shock, and this has been shown in some published series. In heart failure shock, the left ventricle is more afterload sensitive because the LV is more dilated than acute MI shock, and the peripheral circulation is more vasoconstricted. So those patients have higher afterload and are more afterload sensitive than MI shock, and are likely to benefit more and improve their hemodynamics more with balloon pump than MI shock. So there is still a role of balloon pump, particularly in heart failure shock, but always be ready to escalate. And whenever you think of any MCS, Impella or other, account for unfavorable features. Duration of shock, the longer the shock deterioration has been deteriorating for over 24 hours, or the longer you have waited, you slept on it, the less the benefit, unfortunately. Older age, neurologic status, especially coma scale less than 9, unable to obey verbal commands, unfavorable prognosis. Post out of hospital cardiac arrest, unfavorable prognosis. Severe acidosis, lactate more than 8-10, and baseline comorbidity, advanced PAD, prior strokes, advanced CKD, frailty. The more you have of those, the more you're on the right-hand side of that U-shaped curve, and the less likely you want to be aggressive with mechanical circulatory support. No one of those features by itself exclude the patient from aggressive management, but I think the more you have of them, the less likely you are to be aggressive in your management. Final question here, should you put Impella before or after primary PCI? Like I said, in that trial, they intended to put it before primary PCI in the danger shock trial, although eventually it was about half-half, 47% before PCI. Now, is it better to put it before? The Recover 4 trial with Impella may answer this question. But here is how I do it currently. If you have severe and worsening hemodynamics on more than a medium inopressor dose, I would place Impella before PCI to stabilize the patient and to allow him to tolerate PCI. Because as I explained, hemodynamics often worsen during PCI. You get worse before you get better with PCI. So I would place Impella before PCI, one, to reduce end organ, brain, and renal ischemia while I'm working and to improve the blood pressure and systemic perfusion. Two, to reduce myocardial injury and LV deterioration that may occur during PCI because of those reasons. And Impella will raise the blood pressure and dramatically unload the LV and reduce O2 demand, which reduces myocardial injury. On the other hand, if I have a patient before cath who's stabilized on low to medium dose of inopressors, I may place Impella after PCI. I would do my PCI, then place Impella after PCI, or not at all. If during my PCI I see that the hemodynamics are trending positively, the patient is only on a small inopressor dose, and maybe I'm able to wean it down, then I may not put Impella at all in this patient. So I hope this helps you decide when to put it before versus after. Before, really in the severe and worsening hemodynamics on more than medium inopressor dose. Otherwise, you may wait after, and you may choose not to put it at all after PCI. Additional note here, you have a subgroup of patients who are stable before PCI, but they deteriorate later on in the cath lab or in the ICU. Those patients should be brought back to the lab for Impella as long as they are within 12 hours of PCI as per danger trial. The danger trial included STEMI where shock develops after departure from the cath lab up to 12 hours after revascularization. And those were actually 17% of patients in that trial. Additional fellows questions. First question, should STEMI with shock get an emergent bedside echo before Impella? And my answer is, all STEMI with cardiogenic shock should receive either a quick bedside echo or an LV gram to rule out mechanical complications. Indirectly in danger shock trial, it's implied that most patients did or should receive echo before Impella placement. One, to rule out RV dilatation and failure. Two, to rule out mechanical complications. And three, to rule out LV thrombus. So yes, as much as possible, try to do a bedside echo in cardiogenic shock patients before you do an Impella, or at the very least do an LV gram to rule out mechanical complications. Why didn't women derive a benefit from Impella in danger shock trial? In my opinion, the reasons are twofold. One, the sample is too small, so there may not be enough power to make that analysis. Number two, we do know that women have greater complications with larger sheath. They get more limb ischemia and more bleeding with larger sheath. So it's possible that in women, the early complications were higher, so much so that the early benefit from unloading the LV and providing better tissue perfusion could not counteract those early vascular complications. But as of now, this is still hypothesis generating, and I would still use Impella in women with STEMI shock within 24 hours. Another potential limitation in women is that women have smaller hearts. Remember, in heart failure-related cardiogenic shock, the LV is dilated. But in MI-related cardiogenic shock, acute MI, the LV has not had time to dilate. So the LV is still relatively small, particularly in women. So that can cause issues with Impella because those patients are preload dependent. And when you put Impella in patients who are preload dependent with a smaller left ventricle, you have higher chance of suction complications, which leads to more hemolysis and more need to down titrate the power level and reduce the support from Impella. Another question, in normotensive shock, do you always need to use inotrope? My answer is normotensive stage C shock often needs inotrope, but not always. You can try diuretics and see if they respond before starting inotrope, but don't wait too long. Assess your diuretic response quickly. So you give your diuretic if they are achieving a proper urine output, meaning more than 500 milliliters in less than 6 hours, and they are achieving their target 24-hour urination, then that may be enough. Remember that diuresis not only reduces preload, but it also reduces afterload, which is driven by the LV radius. It also reduces ventricular interdependence and reduces functional mitral and tricuspid regurgitation, all of which improve cardiac output. Also, diuresis reduces LVEDP and improves coronary perfusion. Again, all that can improve cardiac output. So diuresis can improve cardiac output without inotropes. Also, diuresis reduces RA pressure and renal afterload, which improves organ perfusions. So for all those reasons, normotensive stage C shock may improve with just diuresis. But keep a low threshold to starting inotrope on those patients if they have inappropriate diuretic response. And by the way, even stage B with no proper diuretic response may need inotrope as well, as I highlight here. Another question, does Impella improve distal coronary pressure past a significant coronary stenosis? So there was one study that assessed that, and I mentioned it in my Impella talk. One study assessed distal coronary pressure, not flow, pressure past stenosis when Impella is off versus when Impella is on, and the distal coronary pressure improved past stenosis with Impella, which we know isn't the case with balloon pump based on other studies from the 1990s. So hypothetically, Impella may improve distal coronary perfusion pressure even in the presence of stenosis. Question regarding how to follow shock patients and when and how to wean support devices. My answer is the same way we have aggressive algorithm for upscaling in shock, we should also seek to de-escalate devices and drugs as soon as possible, as the longer you keep a device, the more complications you get. We should always follow on these patients 3 sorts of hemodynamics. The systemic perfusion, lactate, very important. We should initially do lactate every 1 to 2 hours while we are stabilizing and escalating therapies. Then once lactate is trending down and once hemodynamics have stabilized, we check it every 12 to 24 hours. We also, on shock patient, continuously follow systemic hemodynamics, meaning blood pressure and aortic pulsatility, and we continuously follow invasive swan hemodynamics. And here regarding systemic blood pressure and pulsatility, compare those to tracing. This is somebody who's fully dependent on the Impella support and he has no pulsatility. It's a flat arterial waveform. That patient is not ready to be weaned off. He's still very sick. Compare it to this patient who's having good aortic pulsatility. His LV is able to generate a stroke volume, intrinsic stroke volume on top of the Impella. So aortic pulsatility of over 30 millimeter of mercury is reassuring in a patient with Impella. Compare this versus that. So we follow lactate when the patient is stable every 12 to 24 hours. We follow systemic blood pressure and pulsatility. And we follow those SWAN hemodynamics. Mixed venous O2 over 55%, cardiac index over 2.2, RA and wedge pressure must be less than 12 and 18 to be ready to be weaned, and cardiac power output. Fellows sometimes forget to follow that. We should always follow that powerful predictor of outcomes, cardiac power output, which is cardiac output multiplied by mean blood pressure divided by 451. We want it to be at least over 0.6. So those are the three types of hemodynamics we follow. Echo may help and may also be used as a fourth parameter, and what we can monitor on echo is mainly LV and RV sizes and contractility. Reduced LV, RV sizes and increased contractility compared to baseline also are favorable toward weaning. So when you meet those criteria, particularly those three hemodynamic conditions, and you are on low dose of 1 and maybe 2 inopressors, and in danger shock after at least 2 days of full Impella support, then you are ready to start trying to wean the patient down. And the way you wean the patient down from Impella, there are 2 ways. There is a slow way, which is the most traditional way, and there is the fast way. In the slow way, you reduce P level of support by 2 P values every 4 hours until you reach P2. So you go from P8 to P6, P4, then P2, 4 hours between interval. There is a fast way where you go down from full support by 2 P levels every 5 to 10 minutes quickly toward P2. This fast weaning may be considered in MI patients with very good hemodynamics and with echo showing near complete recovery of LV and RV function. The slow one is the more traditional one, and you should consider it in heart failure shock, those advanced heart failure shock in whom less LV recovery is expected, or in MI shock with less LV recovery on echo. And regardless whether you do the slow or the fast weaning, at each level of weaning, like say you go from P8 to P6, P4, at each level you recheck the hemodynamics and the lactate and the pH. If trending up, then you should resume high-level support and reattempt weaning in 24 hours. Do not reattempt weaning in less than 24 hours. In the interims, try to address the cause of failure to wean. Do more diuresis, small dose vasodilators if possible. On the other hand, if lactate and hemodynamics remain stable at P2 level of support, then you're ready to explant. And this is the weaning protocol used in danger shock trial. It's somewhat similar to what I just described, and those are the maximum doses of up to 2 inopressors that they allowed before weaning trials and eventual explantation. Again, they mandated at least 48 hours of full support before you try to wean. Another question regarding the pressure volume loops and the effect of various devices on pressure volume loops. So here is a basic explanation of pressure volume loops. Where you are on the top line here is your afterload, and where you are on the bottom line is your preload. The stroke work corresponds to that pressure volume loop area, but the O2 consumption also corresponds to the LV tension area on the left of the pressure volume loops. And the whole area of stroke work area and that tension area is what we call the pressure volume area, PV area. And the O2 consumption corresponds to all of that area. Now, look what Impella does. Impella dramatically reduces the afterload and the preload and significantly unloads the ventricle and dramatically reduces the O2 consumption, so much so that it allows the heart to rest while it recovers. On the other hand, balloon pump reduces afterload. It also reduces preload, but it increases stroke work. The overall O2 consumption is reduced, as you see that whole PV area is shifted to the left, but not dramatically so. VA ECMO, on the other hand, while providing the best systemic perfusion, it has adverse effects on the left ventricle. It increases left ventricular preload as it does not directly empty the left ventricle, which continues to receive venous return from the bronchial vein and the Tebesian veins. It also increases the left ventricular afterload. Therefore, VA ECMO increases that pressure volume area and increases O2 consumption the most. That's why when we use VA ECMO, we frequently need to use Impella along with it to vent that left ventricle. This is what we call ECPella, which is ECMO with Impella. And you particularly need to vent the left ventricle with ECMO when you have no aortic pulsatility or aortic pulsatility less than 20 millimeter of mercury, or when the LV or RV dilate on echo, or when there is no aortic valve opening on echo.